I think clinicians need to think about the patient perspective in almost every situation. For many, many years, I have been teaching people who come to PAINWeek about the key steps of approaching patients with chronic pain. I call those the inside-the-box steps. You assess the patient, you do whatever you need to do to arrive at its differential diagnosis, you arrive at that diagnosis, you formulate a treatment plan, you implement it, you reassess the patient, and then you send them on their way, and then you follow them, and if you stay within those lines, you stay on the rails. And what I have come to realize is that as we understand that patients are truly individuals, there are many, many things that patients bring with them that the standard assessment process is not going to capture. Emotional states, emotional challenges, cultural challenges, cultural differences, different external pressures that they have in the context of their lives. And what I am trying to get clinicians to think about are all of the things that the patient might be keeping inside their head that they might not be sharing with the healthcare provider that would hinder the healthcare provider from truly tailoring a treatment plan to the person that's presenting with the chief complaint. On paper, you could do a very good job of checking off the boxes with all of the things I've taught people to do over the years. But none of that really has to do with the contextual experience. Somebody who's got to get up in the morning and go to work versus somebody who wants to get up in the morning and care for their children are two very different people. And they could have the same pathophysiologic problem. They could be exactly the same gender, age, race, everything else you want to categorize them by. But they could be very, very different people in the context of their lives. Like it or not, we judge, and we bring precognitive judgments and precognitive thinking into the room with us every time we see a patient, probably before we even meet the patient. We judge them based on what we see on the paper we read about them before we ever meet them. Patients also do the same thing. Patients judge themselves, patients judge us, and there's all of this precognitive thinking that's going on that could, in very many situations, corrupt the process and corrupt the treatment plan. So my goal is to try and help people understand those kinds of things and reflect about those kinds of issues and bring them into the clinical setting to try and develop things like trust, open, candid relationships, empathy, candor, honesty, integrity, and none of those things exist inside the box. They're all outside the box, but they're there, and they need to be taken into account. There are two ways that we've heard over the years to approach patients with chronic pain. A mechanistic approach, where you could literally drill down to the pathophysiology, down to the nerve level, and say, okay, from a very scientific perspective, here's what we need to treat. Or a humanistic level. And what I'm really trying to say is that there is no such thing as a patient who's not a human. They could be a good human, they could be a bad human, they could be a challenging human, but they're human. And you cannot treat a patient with chronic pain if you don't take into account the human characteristics that exist around all the data we've been trained to capture about them.